grant as well. I would like to remind members that with regards to the suicide study, if you still have witness names you'd like to add to that list, I'll just remind you of the June 15th deadline for additional witnesses so that the analysts can plan the logistics of that trip and that study. And then finally, you may recall at our last meeting we talked about having each member indicate which of the communities that we're visiting are mandatory to you and which would be nice to have. So what Michelle Legault has kindly done as our clerk is prepared a little form. It's easy to fill in. You sort of check boxes. So I'm going to just ask Michelle to pass that around, and perhaps the staff members that are with you or you yourself might get that done while we're here today. That would be great. But if not, certainly if we could have that completed form back for Thursday's meeting this week, that would allow us to then build a budget and proceed with the study. So thank you very much for that. Let's go right in then. We're very happy to have some guests from Indigenous and Northern Affairs Canada. We welcome Paul Isaac, the Assistant Deputy Minister, Education and Social Developments Programs and Partnerships. Welcome to you. Danielle Leclerc, Director General of the Community Infrastructure Branch, Regional Operations. Welcome. From Health Canada, Keith Kahn is with us. He is the Assistant Deputy Minister of Regional Operations. And Dr. Tom Wong is here again, Executive Director, Office of Population and Public Health. And from the Canadian Institutes of Health Research, Dr. Alain Baudet, the President. Welcome to you all. I would like to invite you to speak for, I understand there will be 2 speakers, is that right, today? 3 speakers. Okay. I would invite you to, is it the committee's pleasure to, since we have this group for the full 2 hours, I wonder if we might give our speakers 15 minutes rather than the usual 10 to hear from them. Is there a consent among the committee members for that? Pardon me? Oh, bell's at 5:15. Well, because Kathy McLeod reminds me there'll be some bells at 5:15 for a vote at 5:30, perhaps we should stick with the 10 minutes if you're able to stay. So I guess that's 5 minutes apiece. So let's move quickly then. And
they were given 10 minutes each.
Oh, we're given 10 minutes each. So 10, 10, and 10? Okay. Late breaking news. Rather than 5 each, I understand we previously arranged that you would each have 10 minutes. So 10, 10, and 10. That would be wonderful. Thanks, and let's get right to it. Whoever would like to start. Thank you.
To begin, I would like to acknowledge that we are on the traditional territory of the Algonquin people. Thank you for gathering us here today and inviting us to speak on this very important issue of suicide in Indigenous communities in Canada. As a physician and as a father, the death of a child is heartbreaking. A death of a 10-year-old child by suicide compounds that heartbreak as the profound impacts spread across families and communities. The circumstances are tragic and difficult to comprehend. When we ask ourselves why, we must acknowledge the impacts of colonization, which continue to affect Indigenous peoples today. The Truth and Reconciliation Commission has offered Canada the knowledge and recognition that policies of forced assimilation have assaulted and suppressed Indigenous culture for as long as Canada has existed as a nation. As a nation, we now have an opportunity to recognize that the introduction of the reservation era in the 19th century, the residential school experience in the 20th century, and the forced adoption policies of the 60s and the 70s are just examples of policy that led to eradication of culture and loss of language, erosion of traditional values, and the disintegration of traditional family structure. These impacts have passed down through the generations, and these effects are often referred to as intergenerational trauma, and it has led to the tragedies that we collectively face today. Health Canada, through the First Nations and Inuit Health Branch, recognizes the need to reset its relationship with Indigenous partners, and through these relationships, support community-led, comprehensive, culturally founded, and culturally safe services that are integrated into a broader continuum of wellness programming. Notre travail est guidé par l'engagement politique inclusif et participatif.
We believe that we must move towards an inclusive approach to relations with First Nations and the Inuit. As we see in various frameworks, we must work in partnership with these organizations.
To promote the health of Indigenous peoples, I advocate for equitable programming to address social determinants of health, to strengthen prevention, diagnosis, treatment, support, surveillance, and data for public health actions. In Canada, the rates of Indigenous suicide are much higher than the general population. The overall Canadian rate has declined, while in some Aboriginal communities, rates have continued to rise. In general, risk factors for suicide include depression, hopelessness, low self-esteem, substance use, suicide of a family member or a friend, history of physical or sexual abuse, family violence, intergenerational trauma, poor peer relationships, social isolation, poor performance in school, and unemployment, to name just a few. Protective factors that contribute to resilience include family cohesion, good communication and feeling understood by one's family, involvement in family and community activities, Indigenous language, cultural knowledge, activities with elders and traditional healers, community self-determination, good peer relations, and school successes. Suicide is just one indicator of distress in communities. For every suicide, there may be many more people suffering from depression, anxiety, and despair. There are 5 key elements funded by Health Canada to support First Nations and Inuit health: health promotion, health protection, primary care services, supplemental health benefits, and health infrastructure support. Health Canada spends $300 million a year in community-based programming and services guided by mental wellness frameworks. Through a variety of targeted programs, organizations and communities deliver mental health promotion, addictions and suicide prevention, crisis response services, treatment and aftercare, including prescription drug abuse and supports for eligible former students of IRS and their families. Mental wellness teams are community-led teams which provide a comprehensive suite of culturally appropriate services that include, but not limited to, capacity building, trauma-informed care, land-based activities, early intervention and screening, aftercare, and care coordination with provincial and territorial services. Each mental wellness team serves between 2 and 10 communities, depending on community size, location, and need. Health Canada has allocated funding to regions for 10 mental wellness teams. BC First Nations Health Authority also funds a team in BC. However, flexible funding allows regions to maximize the number and reach of teams to address regional needs. The Brighter Futures Building Healthy Communities program, available to all First Nations and Inuit communities, supports improved mental health, child development, parenting skills, healthy babies, injury prevention, and response to mental health crisis, depending on community needs. The IRS Resolution Health Support Program provides cultural, paraprofessional, and professional supports to eligible former students, their families, and communities. The National Native Alcohol and Drug Abuse Program and the National Youth Solvent Abuse Program include funding for 43 First Nations addiction treatment centers and community-based prevention programs that respond to substance abuse. The National Aboriginal Youth Suicide Prevention Strategy supports over 130 community-based suicide prevention projects in First Nations and Inuit communities across Canada. Strategy funding was used to train over 800 community-based frontline workers to provide culturally appropriate information about suicide prevention. We have seen positive results. For example, the Taiga Adventure Camp is a camp for girls, 11 to 17, open to all 33 Northwest Territory communities. The goal of the camp is to increase self-esteem and promote healthy living, relationships, and mental wellness to protect against youth suicide. The camp uses outdoor skill development to provide leadership opportunities and develop confidence and respect for others. Outcomes have shown improvements in confidence, initiative, leadership, and optimism, increased ability to address conflict, and improved knowledge of protective factors. The department is also supporting the development of a web-based First Nations Wise Practices resource that will allow communities to access and implement proven and promising youth suicide prevention strategies. The Mental Health Commission of Canada has been provided with $1.2 million from FNIP to support First Nations and Inuit adaptation of its mental health first aid training. Health Canada, the Assembly of First Nations, and community mental health leaders jointly developed First Nations Mental Wellness Continuum Framework, grounded in culture as foundation. L'application du cadre est soutenue par une équipe.
The framework is supported by an implementation team with members from all regions and communities, as well as from the department.
Also supporting ITK in their work to develop Inuit mental wellness teamwork and Inuit suicide prevention strategy. Both the strategy and the framework are anticipated to be finalized later on in 2016.
1 minute remaining, Dr. Wong.
Okay, thank you. Other federal programs and departments, including but not limited to AANO, Public Health Agency of Canada, CIHR, Public Safety and Justice, provide programs and services to First Nations that address Indigenous social determinants of health, are important partners in this effort. Health Canada is working with partners on an approach based on mental wellness frameworks, which amalgamates mental wellness programming and seeks additional resources to address gaps. Additional resources are required to expand core services and services that help Indigenous peoples, and that any new federal funding will support the long-term goal of transfer to communities and alignment and integration with provincial services. Promising practices of community healing relate to culture and identity, community-based, community-paced, and community-led initiatives with strength-based and holistic approaches that blend Western and Indigenous therapeutic approaches with strong community relationships. While important progress has been made, it is clear that more needs to be done. The levels of health inequity between Indigenous Canadians and the rest of Canada are unacceptable. Health Canada will continue to work with First Nations and Inuit to advance areas of mutual priority. Efforts to support First Nation and Inuit in their aim to influence, manage, and control health programs and services that affect them continue to be fundamental for improving health outcomes and access to needed health services and programming. In addition, Health Canada will participate in a whole-of-government approach to address the recommendations of the Truth and Reconciliation Commission. But this is not something we do alone. Reconciliation is the work of Canada as a whole. I ask you to join us in the efforts of reconciliation and ensure that all children in Canada have access to nutritious food, safe housing, quality education, clean water, and finally, access to a robust and responsive health system. Mr. Chair, I'm glad we have the opportunity to present here today on this very important issue. My colleagues and I would be pleased to respond to the committee's questions at the end of all the opening remarks. Thank you.
Thank you very much for that. And I'll just, I forgot to mention this earlier, I'll hold up a yellow card when there's 1 minute remaining, and a red means please just get right to the closing point. Thank you very much for those remarks, and let's move right along to the next speaker. Dr. Baudet.
Thank you, Mr. Chair. First, I would like to thank as well the committee for inviting me to discuss this critical issue of suicide prevention in First Nations, Inuit and Métis communities. As president of the Canadian Institutes of Health Research, or CIHR, I appreciate the opportunity to share with your committee the vital role that research is playing to address this strategy. this tragedy. As you may be aware, CIHR is the Government of Canada's granting agency responsible for supporting health research in universities, hospitals, research centres, and communities across Canada. CIHR's commitment to address the disproportionate health burden faced by Indigenous people in Canada is steadfast. This is why we have made the health and wellness of Indigenous communities and families one of 4 research priorities in our most recent 5-year strategic plan. When it comes to suicide, science has a critical role to play in helping us understand the root causes of this most complex and sensitive issue and develop evidence-based solutions for preventing it. What are the causes behind the unacceptably high incidence of suicide among Indigenous people, and how to design and evaluate interventions aimed at promoting mental wellness is at the heart of our research efforts. Il faut comprendre que la recherche financée par les IRST.
It is important to understand that the research funded by CIHR on the topic of suicide and mental health covers a vast range of the health sciences from basic to applied. It ranges from studies on the biological basis of depression to investigations of the cultural, social, and environmental risk factors linked to suicidal ideation. It includes, for example, research on the effects of the environment on genetic predisposition to mental health disorders, research on intergenerational health impacts of residential schools, studies linking suicide to variance in exposure to daylight in the north, or the psychosocial impacts of housing conditions. And that's just a few of the areas we research. It is critical to understand the etiology and the risk factors underpinning these high suicide rates if we want to be in a position to meaningfully address and prevent them. Indeed, research on suicide is not only meant to improve our understanding of the problem, but also to help develop evidence-informed interventions and programs. In other words, to translate knowledge into practice. Appropriate interventions can be successful, as demonstrated by Quebec's preventative efforts, which led to a 50% reduction in the suicide rate among its youth. This reduction was even more pronounced among young men. It is imperative that research be leveraged in a similar way to help address suicide in First Nations, Inuit, and Métis community. We are talking about 2 very different sets of research questions and approaches here. The first, referred to as intervention or comparative effectiveness research, is about developing and testing the efficiency of interventions under tightly controlled conditions. The second, referred to as implementation research and delivery science, is about implementing and scaling up successful interventions in the real world. What works, for whom, and under what circumstances? How can successful prevention strategies be adapted and scaled up for different communities and settings? Implementation science needs research to be embedded into care and adapted to socioeconomic and cultural contexts to maximize efficiency and impact.
Implementation science and delivery research is a relatively new area of health research, which we have embraced at CIHR to address a number of global health issues, including Indigenous people's health. Thus, through a major strategic research initiative entitled Pathways to Health Equity for Aboriginal Peoples, we have supported a series of implementation science projects aimed at improving mental wellness and reducing the incidence of suicide in Indigenous communities. For instance, a project led by Dr. Claire Crooks from the Centre for Addiction and Mental Health in Toronto took the mental health first aid program and adapted it to First Nations communities across Canada. This original program had been demonstrated to increase individual skills and knowledge about how to respond in a mental health crisis. It is currently used across Canada. However, previous evaluation studies had found a critical need to culturally adapt the program to First Nations communities. Using a combination of interviews, focus groups, implementation tracking, and surveys, the research studied the implementation of the adapted program in several First Nations communities and confirmed their effectiveness. Another example of CIHR-funded research aimed at implementing research into practice is Access Open Minds, a groundbreaking national research network focused on youth mental health. Through this network, supported in partnership with the Graham Beck Foundation, researchers are taking existing mental health practices and treatments and making them age-appropriate for diverse youth populations. Through testing and evaluation of these tailored youth interventions at 12 sites across the country, including 5 that are working with Indigenous communities, this network will help identify effective approaches for assessing and treating Canadian youth with mental illnesses. A common feature of these 2 research initiatives is that they both involve multiple research sites and allow for learning across communities and between jurisdictions. Crossing jurisdictional boundaries also means developing international collaborations to address suicide prevention. As you may know, the issue of Indigenous suicide is not unique to Canada. Indigenous populations in other countries, such as the US, Denmark, Sweden, and Australia, are facing similar challenges. Now, with some of the causes and manifestations of suicide, while some of these causes differ across countries, as they do across Canada's First Nations, Inuit, and Métis communities, there are also important points of commonality and overlap. As such, this shared problem presents an opportunity for joint research efforts and sharing of best practices across borders. This is why, since 2013, we've been involved in international research efforts to address suicide prevention in Northern Indigenous communities through the Arctic Council. Under Canadian chairmanship of this international forum from 13 to 15, CIHR spearheaded a research initiative involving researchers and community members from across 4 Arctic countries to identify promising practices in suicide prevention. These efforts culminated in an Arctic symposium in Iqaluit held in March 2015, where researchers shared best practices in suicide prevention, a symposium that was hosted jointly by CIHR, the Government of Nunavut, and international partners. As a second phase of this work, we're now partnering with the United States National Institutes of Health on a follow-up project to further address suicide in Arctic regions. Through this follow-up initiative, called the Rising Sun, partners from across the Arctic states are coming together to identify common metrics to track suicidal behaviors, key correlates, and outcomes, so as to facilitate data sharing, evaluation, and interpretation of interventions for suicide prevention. CIHR will soon be launching another major international research program on global health, mental health, through the Global Alliance for Chronic Diseases, or GACD, an international consortium of health research funders that Canada currently chairs. This program, which with a combined international investment of over $60 million, will fund research into the prevention and management of mental disorders with a focus on interventions in low and middle-income countries, as well as in vulnerable populations in high-income countries, including Canada's Indigenous populations. Once again, through this opportunity, CIHR will be able to leverage knowledge from international contacts that is relevant for Canada and will provide tools to tackle the issue of suicide in our communities. Ce ne sont que quelques exemples nationaux et internationaux de la manière dont nous appuyons la recherche.
These are just a few national and international examples of how CIHR is supporting research to address wellness and suicide prevention in Indigenous communities. Through basic science and applied research initiatives such as Pathways and the Rising Sun Initiative, CIHR is committed to continue supporting research to identify ways to promote resilience and positive mental health among Indigenous people, and to ensure that research evidence is brought to bear on policymaking through effective knowledge translation. In this regard, CIHR will look forward to continue working with Health Canada and other federal, provincial, and territorial partners to help inform policies and programs related to Indigenous health. Before closing, I would like to take a moment to underscore that all of the CIHR research projects in this area are designed and carried out in close collaboration with Indigenous communities. Our ultimate objective over the long term is to develop and support a cadre of Indigenous researchers as they are best positioned to understand from the inside the cultural determinants of mental wellness. This is why strengthening research capacity within our Indigenous population is at the heart of the CIHR agenda.
That research is only part of the solution to this very complex and challenging issue, but it is an important one for identifying the most effective path to identifying wellness. Mr. Chair, thank you again for this opportunity to share our work with you in this critical area. I look forward to your questions. Thank you.
Thanks very much, Dr. Baudet. The next speaker, I believe, is Paula Isaac. Thank you.
Right, thank you. And good afternoon, Mr. Chair and members of the committee. I would like to thank the committee for this invitation and would like to also acknowledge that we are gathered on the traditional Algonquin territory. This is an important study, and I want to offer INAC's full support as it evolves. As my colleagues have noted, suicide is often the tragic consequence of a complex array of factors. Cela comprend des problèmes de santé mentale comme la dépression.
That includes mental health issues such as depression as well as substance abuse, social and family factors, poor performance in school, and bullying or relationship issues.
But one of the contributing factors to high suicide rates among First Nations Inuit, including youth, is inadequate basic supports. For example, these can include a lack of income supports, education opportunities, adequate housing, or health and social services. These factors of instability have direct repercussions to the decline of mental health in Indigenous communities. And each element is part of a continuum that is vital to providing a sense of hope, to wanting to go on in life, and to seeing oneself contributing in society. Je comprends que le comité, entre autres choses,
I understand that, among other aspects, the committee will be studying these risk factors broadly, as well as protective factors that promote well-being and help reduce vulnerability. This broad approach is helpful because so many players are involved in ensuring that those basic needs for Indigenous communities are met.
For my part, I'll frame my remarks around those elements today in order to best provide context on INAC's roles and programs. INAC, as you know, is a focal point at the federal level for Indigenous issues. We are one of 34 federal departments responsible for meeting the Government of Canada's obligations and commitments to First Nations, Inuit, and Métis. Le ministère fournit un soutien financier aux collectivités.
INAC provides financial supports to First Nation communities to deliver services on reserve. This includes education, housing, and social support to Indigenous peoples.
Our social programs aim to assist First Nation individuals and communities to become more self-sufficient and promote strategies to reduce the risk factors that negatively affect the health and well-being of communities. Embedded in many of these programs is funding for prevention. It supports Indigenous families and communities in taking steps to avoid situations of crisis and in achieving improved outcomes, whether it be in the care of children or generally support for greater participation in the labour market. Le ministère verse des fonds aux bandes des Premières Nations et des organisations.
The department flows funds to First Nation bands, organizations, and in some cases, provincial service providers who provide on-reserve residents with individual and family social services that aim to offer culturally appropriate programming to meet the needs of those individuals and families.
INAC also provides funding for a suite of elementary and secondary programming through core funding and complementary targeted request and proposal-based education programs that seek to focus on specific aspects of education support and success. INAC's elementary and secondary education program funding is part of a broader investment strategy in First Nations children and youth. In addition to supporting elementary and secondary education, INAC also provides support to First Nation Inuit students to attend post-secondary institutions. Health Canada and the Public Health Agency of Canada provide early childhood programming, such as Aboriginal Head Start, which helps promote school readiness among Aboriginal children. And Employment and Social Development Canada has labour market programs tailored specifically for Aboriginal Canadians, including First Nations Job Fund and Aboriginal Skills and Employment Training Strategy. Departments are increasingly looking out for ways to enhance cooperation. In all cases, the programs are intended to be community-driven. Les programmes de ce genre sont efficaces pour favoriser la création des collectivités fortes.
These types of programs go a long way toward promoting stronger, healthier communities and toward reducing vulnerability and improving mental well-being.
The fundamental challenge before all of us is improving the foundations upon which Indigenous communities can thrive. And when those basic needs are not met, it is a tragic reality that crisis and emergencies could occur. In those cases, as the committee knows, both our minister and departmental officials engage quickly with local leaders to discuss how best to give immediate and long-term help. Certainly, this outreach informs our ongoing efforts on how to proceed to meet the Government of Canada's commitment to working on a nation-to-nation basis and improving health and social outcomes in First Nation communities, identifying program support for required services, and strengthening the resilience among children and families on reserve. Dans tous les cas, la collaboration entre les partenaires est essentielle.
In all cases, collaboration between all partners is key in working toward ensuring the continuum is working, that basic needs are in place to not only address crises when they occur, but more importantly, prevent them from happening in the first place.
As part of the historic budget 2016, $8.4 billion in investments, the department is tracking in providing is on track in providing First Nation recipients with the first round of investments. Much of this early budget funding is earmarked for addressing basic needs. As that moves forward, INAC remains committed to delivering on the government's promise of a new fiscal relationship with First Nations to provide sufficient, predictable, and sustained funding for First Nation communities. I can also report that the Minister of Indigenous and Northern Affairs Canada continues to work with Cabinet colleagues on several early key initiatives, as outlined in the respective mandate letters. Elle porte, entre autres, sur l'enseignement primaire et secondaire.
This includes elementary and secondary education, the First Nation and Inuit youth employment strategy, and post-secondary education.
Our department's work also contributes to meeting the Government of Canada's commitment in addressing the Canadian Human Rights Tribunal's order to reform the First Nation Child and Family Services Program. We are also moving with all partners in moving toward meaningful engagement and forming options for program reform. Recently, departmental officials also joined the minister in announcing full support for the United Nations Declaration of the Rights of Indigenous Peoples. One of the principles of that declaration reads that the Indigenous individuals have an equal right to the enjoyment of the highest attainable standard of physical and mental health. Le ministère est décidé à travailler en collaboration avec des partenaires.
The department is committed to working in collaboration with partners to ensure that these gaps between Indigenous and non-Indigenous people are closed, and to help First Nations, Inuit, and Métis people improve wellness.
On one front, the department and minister spent the months from December to February engaging with survivors, family, and loved ones, Indigenous organizations and governments, provinces, territories, and experts on the design of inquiry into missing and murdered Indigenous women and girls. We expect that this inquiry will also shed more light on many of the conditions that lead tragically to suicide in some communities. I will also highlight that the Minister is working with Ministries of Families, Children and Social Development to launch consultations with provinces and territories and Indigenous peoples on National Early Learning Childcare Framework. This is a first step towards delivering affordable, suitable, high-quality, flexible, and fully inclusive childcare. A key component of combating this ongoing tragedy is working in partnership with Indigenous communities to promote and ensure that Indigenous peoples have a secure personal cultural identity. This is a key issue for the Minister and our department. I am sure my colleagues at Health Canada will attest to the evidence that shows a stronger sense of identity and self-sufficiency can, in fact, lead to reduced rates of suicide in Indigenous communities. Comme mes collègues et moi-même l'avons remarqué,
as I and my colleagues have noted, to truly improve the situation for Indigenous peoples, we must focus squarely on improving the socioeconomic conditions they face.
We will continue to reach out to provinces, territories, Indigenous leadership, and others to find concrete solutions and look at long-term needs in mental health, child welfare, education, infrastructure, and employment in Indigenous communities. I look forward to the advice, support, and dedication of this committee as we move the yardstick forward together on these issues. I'd be happy to answer any questions at the end. Thank you very much. Merci.
Thank you very much, Ms. Isaac, for that and for all of the speakers. I think you've all been through this before. You know, we'll move now into a round of 7-minute questions, and I'll continue to use the yellow and red cards. Sometimes it will be the responder getting the card, sometimes it will be the asker, and I just would invite all the members to try to come to their question with as little preamble as possible. So jumping right in, we'll begin with Don Rusnak, please.
I'm going to be as brief as possible, but we know that this is an absolutely complex issue, that there's many layers and there's ideas for solutions. I personally look at this as a short-term problem where we're reacting to the crisis, the immediate crises, which are absolutely horrible in these communities. And that'll form one of my questions. But ultimately, long-term, we're going to have to look at long-term solutions to make sure that the communities, the First Nation communities and the Indigenous populations aren't facing these horrible issues. I am familiar because of my work and for the benefit of my committee members who've heard me talk many times, I've worked with First Nation organizations over the years. I've worked in First Nation communities at different capacities with different governments. But the first question is what, in terms of, I guess this question will first be one to INAC and one to Health Canada. What have you come up with in terms of immediate solutions and immediate programs to deal with the immediate crises? Are you just ad hocing it, or is there actual crisis teams that are on standby? Because we know the problems are entrenched in the communities, so we need that immediate response to the crises to make sure the communities get the support that they need right away. So is there a plan in place? First question for, I guess I'll go to Health Canada.
Well, thank you very much, for the question. Yes, indeed, crisis needs to be actually dealt with in the context of, needing to deal with, the long-term issues. Regarding the immediate crisis, there were a number of things, already in place. I spoke about, the small number of mental wellness teams across Canada, that have been mobilized and can be mobilized, to help deal with emergencies. Now, within that context, of course, it has to be, working together at the invitation of the First Nations communities and also in collaboration with the involved province. So most recently, for example, with Atawapiskat, the invitation, by the province and the invitation, of the community to actually, assist. So it's a collaborative effort. Now, the reason why I actually mentioned that, the number is small is because as you can do the math, there's, Canada's a big country, so 10 mental wellness teams, are a good start, but, we need, more in order to actually do a better job. As far as, what to do, with emergencies, I think that one should actually think about, before dealing with emergencies, one should actually think about, is there a way to actually prevent emergencies? And those are some of the elements, social determinants of health, reconciling, about Indian residential schools, and TRC recommendations, all of those things that need to be actually in place. With that, I'm going to actually, perhaps, turn to my colleague, Paula, regarding some of the social determinants of health work that, her department has been actively, working with the communities.
Yes, I think the long-term solution is around, as Dr. Wong was talking about, ensuring those basic underpinnings are solid. So that's ensuring that the education supports, the labor market supports, income supports are there to ultimately prevent these from happening in the future. So those are long-term solutions that need to be done really with the communities jointly and collectively. So there is not one strategy for all communities writ large, but there are strategies that need to be developed with those communities. So that's certainly the commitment our department has, certainly with our Health Canada partners. Health Canada is there at the front lines when some of these crises happen, but we're right there with Health Canada partners and working with the communities to what are the key underpinnings that need to be strengthened. So
immediately, is INAC working with these crisis teams, either with by their contacts within the communities to make sure that they're localized? And so this is probably a two-part question, what are the outcomes or what are the successes of these crisis teams going in? What has been the reception in the community and what's been the result?
Do you want to speak to that?
Yeah. INEC, and Health Canada, work hand in glove, with some of the activities in response to crisis. For example, with crisis, we know that there are some long-term issues that need to be addressed, but there are some short-term approaches that actually can already be, instituted. For example, when we actually hear, from the youth that there's a need, for more books, better schools, a place to play sports, programs to actually link up with elders. Those activities, some of those activities, and some of the linkages, they do not need to actually wait for 2 years, 3 years, 4 years to actually build a center. Those are some of the things that actually can be done, very quickly. And so those are some of the practical things that we have been actually at Health Canada have been working with the communities to actually try to actually facilitate some of those linkages and activities. To me, nothing is as important as linking a youth who sees no hope, no meaning in life, and yet disconnected from culture, to be able to facilitate the connection with their elders, with their culture. So,
okay, I'm just going to cut you off there because I want to get a question to my friend from the Dr. Alain Baudet from the CRHR. I see I have 1 minute left. So targeted research funding in suicide prevention to build research capacity at the community level, build partnerships with communities. How many community-based research projects in suicide prevention research were funded, and what are the outcomes of those funded projects?
So we've been funding a number of communities. I can follow up with the exact number because different projects will fund different numbers of communities. We've been funding particularly through major strategic initiatives in implementation science, as I said, which actually aim at integrating research and care. So not only implementing an intervention, but ensuring that the intervention as it is being implemented has a research protocol built into it so that you can actually analyze the results, determine if the intervention is effective, and if it's not, how you can actually correct the course to improve it. We've done that with multiple communities, actually, and particularly in the Access Open Mind project. And the advantage of it is that we then bring the researchers and the network together so that we can compare notes of the effects of the interventions of the various communities. And I think that what I could best do to illustrate the impact is perhaps read you an email that I received from the chief of Eskasoni First Nation. He writes, I've been on board with being involved with the jointly funded CITRA Graham Beck Foundation Access Open Minds initiative since day one. With more than half of Eskasoni's population being under the age 25, I and my fellow council members are excited that Access Open Minds will build upon our current model of mental health addiction care and make our services even better. We believe that this enhanced model, which includes and blends case management, care facilitation, 24/7 online, in-person, and toll-free crisis intervention, peer support, life experience, sports, recreation, and Aboriginal cultural and traditional teachings with Western therapeutic interventions, therapies, and practices, can be implemented successfully by others throughout Canada. End of quote.
Thank you, Dr. Baudet and Mr. Resnack.
The chief with my friend Jaime Batiste, who's from Eskasoni, and he'll actually be here this weekend or this week meeting with me and Phil Fontaine.
Thanks.
Plug.
Kathy McLeod, please.
Thank you, and thank you to the witnesses. This is a quick question. We know that the rate is horrific. It's unacceptable. Since 1980 to 2016, has the suicide rate decreased at all in Indigenous communities?
the question is a complex one. The reason why is that surveillance or information gathering is very specific to each community, and therefore, as a country, currently the statistics for Canada as a country, and specifically for First Nations on reserve nationally, that information does not come on a day-to-day basis. That only comes, when there's periodic surveys when that's actually done.
So I'm trying to make this. I thought that could be a quick sort of. Is your sense then that we are making any headway on this issue, or are the rates as horrific as always?
There are
Just
some
a quick answer.
Good. There are some communities, unfortunately, we are actually seeing increases in suicide, whereas there are some communities actually are not experiencing any suicide or actually experiencing decrease in suicide. So
thank you. So we've got a whole myriad of programs, and I'm glad to see that CIHR is starting to really focus, because I think that's going to be critical in terms of. Because, Aboriginal Head Start's been around forever. The NADAP programs, there's been programs that are around, and if they're not working, I think we need to start to refocus support. And obviously, the biggest issue is the upstream. My next question, and hopefully, again, this is a quick one. It was on the headlines this morning in the Ottawa Citizen, a young Indigenous person who clearly was having challenges, and the doctor was so horrified that they felt they had to speak out. So when those sorts of things happen, you talked about the mandate being working with the provinces and territories. Do you ever sort of take an incident and, give that doctor a call and say, what the heck's going on? And have you got a system in place with the provinces where you can use a case study like that to improve things? Because again, so did you pick up the phone, or did anyone in your department pick up the phone in terms of that, apparently it sounded very horrific in terms of a local case?
Yes, in a situation like that, what our department does, is go through, the province to actually liaise with the province and have actual discussion about that. I think that particular example, is, something that can be of major concern to all Canadians. If all the facts that's described in the newspapers, are there. The reason why, is we need to actually think about the circumstances where an Aboriginal youth, who's very scared and end up in a facility. And so the question, is what is the most welcoming way to actually help this youth? Of course, we don't know the circumstance. We don't want to comment on the individual circumstance.
I understand that, and not everything I know as well as many, that not everything reported is all the facts. But is there a system in place that you immediately take action?
Yes, please.
I'll try to support my colleague. It's Keith Kahn. Yes, the phone is picked up to answer your question. I'm not sure of this particular case, but when there's, for example, disturbing prescription patterns for an individual client, we do have a tracking system, and that's a call from our head office to that prescriber or that pharmacist. We work closely with the various provinces and territories. We have I wouldn't say a hotline, but a direct line to senior officials to say, we have an issue, this person's in Toronto, they're stranded, they're going through a crisis, how do we work cooperatively together? So yes, we have navigators as well that are out in the field working for First Nations communities to champion or to help clients that are in a distressing situation, or that could be leading to some high risk situations. So yes, we pick up the phone, call pharmacists, doctors, or our connections within the various ministries of health to kind of resolve the issue.
Okay. So my next question is to Dr. Baudet. You alluded briefly to two things, and maybe if you can table. You said that at the Arctic Council meetings, you share best practices. Is there a public document that can be ultimately tabled?
There are several documents, and we'll be happy. Certainly, the report of the project, the outcome of the project during the 2 years of Canada's chairmanship is out, and we'll be happy to send this report to you. As I said, we're pursuing now. It's great that under the chairmanship of the United States, they've decided to maintain the project, build up on it, and we saw what were the gaps from our first studies. One of the problems that we realized was that we all started with wanting to not only look at the interventions that had been successful in Canada, but could we learn from interventions that had been also successful in Greenland, successful in Alaska, successful in northern Sweden and northern Norway, where, as you know, there are also extremely high suicide rates among Aboriginal youth. And we realized that we had a difficulty to actually compare the studies because of the lack of metrics and standardized metrics. It's one thing to measure suicide rates, but there are also of other metrics in the interim that could actually inform whether an intervention is successful or not, and whether we're actually changing roughly the mental health course. So that's what we're doing now, and Canada will be hosting a major end of term symposium on this case in Italy.
So they have me down in my last minute. Could you also table, because there's no time left, you talked about a very successful Quebec project, their preventative initiative, 50% reduction in suicide rate, if that specific could be tabled.
Absolutely. So it's been a major program launched in Quebec for preventing suicide. The results have been amazing, actually, in decrease. As you know, Quebec had the highest, and among the provinces, the highest rate of suicide in the youth, and the effect of a systematic approach to prevention has massively decreased the rate of suicide in the youth, and we'll be happy to send you info on this.
Thank you.
Thank you for that. Next question is from Charlie Angus, please.
Thank you very much for participating in, I think, what could be a very important study with all our members of Parliament trying to deal with some of these issues, and I hope we will see you again as more evidence comes forward. Certainly, the issue of suicide is very complicated, but in some ways it's also very simple, in that the agencies, the adults, the institutions whose job it is to protect children are failing them. And that's what we need to look at. I bring forward the case of 14-year-old Azrea Kopanens, who died in a horrific death in Lake of the Woods. She was involved with child welfare. She was involved with police. She was brought to a hospital, walked out of that hospital in the middle of the night, and the body was found 2 days later. The family is asking for an inquest, and I don't want to deal with the individual case, but what was raised in that story, that tragedy, was that she tried to get mental health services, and mental health services were not available. In fact, in Queen's Park today, in calling for the inquest, MPP Sarah Campbell said, to be clear, these services don't exist. So, do you keep records, statistics, of the amount of requests for mental health services for youth at risk? Do you keep records of how many are denied? And do you have records of what the delay rate for treatment is?
Thank you very much for the question. Yes, indeed, we are very concerned about, the state of mental health services, in Canada in general. This is both on reserve, off reserve for Indigenous peoples and non-Indigenous peoples as well. But specifically in remote and isolated areas, there's a particular challenge. Yes, to answer the question, our department does, have records of, people requesting, for mental health services, and the department does actually provide through contracts, those services by contracting with professionals to actually provide those services, both in person as well as through telehealth arrangement.
Okay, thank you. I only have 7 minutes. That's why I'm being curt here. In our communities that I represent, I hear all the time that people are denied service, or they wait so long the young people go to ground, and we've lost young people. So, would you share those statistics? with us so we have a sense of what the delay rates are, because if we're being told that mental health services simply do not exist in parts of the country, then what else can we expect that these young people are going to fall through the cracks? So would we be able to get those statistics?
Yes, we'll be happy to actually provide those statistics. And it is, really important to us that anybody who actually wants and needs mental health services, need to actually get those services, because they're going to get the services to want to get help.
Yeah, okay, thank you that's excellent. So now you'd said that we've got 10 mental wellness teams in the country, so there's 634 First Nations, and you say they represent between 2 and 10 communities that they service, so that's between about 3% and maximum 20%. AFN said we need 80. Have you costed out what it will take to get us to the full complement of mental health wellness teams?
If we actually, wanted to actually look at the utopia situation, yes, we want to actually, go up to...
It's not utopian.
Yes.
This is about making sure that every community has a mental health wellness
Right.
team so kids aren't killing themselves. So you say you've got 10, they say there's 80. So have you costed out what it would take to get us there?
Right now, we are actually doing the calculation on how much that would cost. Yes, and we very much like to expand those mental wellness, team services. Indeed.
That'd be great.
And those mental wellness team services, not just providing the services when there's no crisis, but also to try to prevent the crisis from occurring. And then when crisis happens, is to help the community with dealing with the crisis and mobilize other crises, other teams into the community to assist as well.
So we're 70 short, so if we can get the numbers on what it'll take to get us there. Because I noticed on the mental wellness continuum that only $350,000 was allocated. We did ask Health Canada about this time, or last time they were there. How much would you need to get the full implementation of the mental wellness continuum framework?
The implementation of the First Nations mental wellness continuum framework is, much more than the 350,000, because everything that was done up to the point when the mental wellness continuum framework was developed, was compatible, with the
But within the
Cultures
framework, there's
Foundation.
only 350,000.
Yes, but the 350 was purely the very first tiny step to do the pilot studies, and in order to actually have.
So what will it take to fully implement?
It would actually have to actually increase that to 2 to 3 times the amount that is currently in the budget. So currently we have $300 million a year.
Okay, so I want to go back to the story of the young woman from Lake of the Woods, because the other element was child welfare. Now, Canada has been found guilty of systemic discrimination in the Jordan's Principle case, and in paragraph 458 of the Human Rights Tribunal cited that the 65 agreement in Ontario is discriminatory, and ordered in paragraph 474 that INAC cease its discriminatory practices. And yet, I haven't heard that there's been any change to the 65 agreement to bring the government in compliance with the Human Rights Tribunal. Will that be happening this year?
Just 1 minute remaining, please.
Thank you.
Sorry. Yes, absolutely. The 65 agreement does need to be changed. It does need to be changed in partnership. We can't change it unilaterally. So what the first step was an initial investment, an increased investment in Ontario for child welfare, but recognizing that the 65 agreement is the framework in which child welfare is delivered, so that needs to be reformed in partnership. So we've just started those discussions, and we'll definitely need to continue those discussions over this year to come to a...
And will that include mental health?
It will depend on what are the needs that come out of those discussions, and then we'll bring in our partners as necessary, whether that's Health Canada or others, to look at that.
Thank you very much.
Thank you. Next question is from Michael McLeod, please.
Thank you, Mr. Chair, and thank you to the presenters. This is a very serious, very important issue that's been around for a long time, and I've sat in many meetings, many conferences where we've heard study after study, conferences after conferences, symposiums, all looking at this issue. We've heard today that there's 34 departments that are kind of involved in dealing with the conditions that Aboriginal people are facing in the social area and the economic area. And yet, in my riding, in the last 15 years, we've seen an increase in suicides. We're up to 123. You add Nunavut to that, there's another 500. So we're well over 600 suicides in the last 15 years while we've been studying this. Since this committee started this undertaking of talking about suicide, I've had 2 suicides in my riding. And this is a short period. It's a serious issue. I don't see who's taking ownership of it. I hear you talking, one department talking, another department talking. But where's the strategy? Where's the combined effort to work together? Who is the lead? Who is leading the strategy, and where's the action plan is my first question. My second question is, why aren't we involving Aboriginal organizations in this? I don't see, and I work closely with Aboriginal governments. I talk to them every day. And I don't see Aboriginal governments being included except to be consulted when there's a study. But there's friendship centers that are not being utilized. There is no strategy for the friendship centers to be used. The Aboriginal Head Start is sitting in health. Why? Why are they in health? They're an Aboriginal program. There is no strategy for Aboriginal Head Start to do anything anymore. Yet some of the solutions involve languages, education. But that's not being inclusive. So I want to ask you to explain to me how we're moving forward in a unified position to deal with this issue.
Perhaps I'll start, with the response, and then my colleague at, INEC, perhaps, can chime in as well. Indeed, actually, we do have a number of frameworks and strategies. Those are limited in scope at the moment. For example, we have the National Aboriginal Youth Suicide Prevention Strategy. And that strategy is limited in scope because it only deals with prevention, primary prevention, secondary prevention, and tertiary prevention. There are, just as you said, there are, many upstream items, that's not covered. For example, education, culture, et cetera, et cetera. So all of those needs to be actually built onto, this pre-existing National Aboriginal Youth Suicide Prevention Strategy in order to make it a comprehensive strategy. Because one cannot just go with a health-only approach. One needs to actually deal with all of the other sociocultural factors, housing, et cetera, et cetera. And for that, we are absolutely very, very interested to work with any sectors, who are interested on the issue, of working with Indigenous organizations. We've been working very closely with AFN as well as with ITK. We work with AFN on, co-developing, the framework for First Nations suicide prevention and continuum framework. For the Inuit, we work with ITK to assist them in actually developing their suicide prevention strategy, as well as the mental wellness continuum framework. It's we have regular meetings with those organizations, those national organizations, in learning from them, in offering any assistance we can to them, so that together we can actually help address this very, very complex problem. And we have been hearing from our AFN and ITK partners that they are very interested.
I'm just going to interrupt you because you're not answering my question. My question is, who is the lead on developing a suicide strategy and with all the different departments involved? Maybe you could answer that.
For the strategy part, for the health part, health would be the lead, and we would actually, invite, the, other partners to actually be joining us. Of course, this is from a government perspective. Everything has to be led by the communities, so by the Indigenous communities, and we are there to actually facilitate, the work. And of course, because of social determinants of health issues, we need the support of all federal departments,
Mr. Chairman,
such as INEC.
I'll just cut you off again. I'm not hearing the answer, but we know the highest suicides are amongst Aboriginal people. Usually they're male. Usually they're in isolated communities. Usually they're in communities that are economically depressed. If there was 3 things that you could do immediately to try to alleviate the situation, what would they be?
The first thing, would be the reconciliation regarding the Indian residential school and all the intergeneration trauma. That's extremely important. 2 is to bring hope, bring meaning, bring purpose, and bring belonging to the youth and the children and the parents. And for that, we need, to have social determinants of health. We need to bring the culture back to the youth. We need to actually reinvigorating the importance of self-esteem and the culture.
Okay.
And
One last question. I hear you. Where is that plan? I'm hearing you saying lots of nice things. I've heard you all say good things. Where and when can we expect that plan?
The plan is already in existence with the AFN having worked with us to actually co-develop the First Nations mental wellness continuum framework. All of those elements, are there, and we are going through the next step to actually, implement elements of, that plan, and together with the communities, and together with INEC and other departments.
Yeah, AFN doesn't represent most of the communities in my riding, so.
Thank you, Dr. Wong. We now move to a round of 5-minute questions, and the first question comes from Arnold Viersen, please.
Thank you, Mr. Chair. Thank you to our guests for being here today. Really appreciate your time. Suicide and suicide attempts come from a number of devastating situations. A recent study by the Canadian Medical Association found a strong association between child abuse and suicide, idealization, or suicide attempts. I'm wondering if, from your research, if any of your departments has shown similar associations with between Indigenous youth, child abuse, and then suicide attempts. So, probably the Ministry of Health first.
Yes, there's a strong association between abuse, violence, and suicide.
I see that one of the programs that you have listed here is the Family Violence Prevention Program. I was wondering if you could just elaborate on what that program all entails. Paula.
Thank you for the question. Yes, that's one of the programs that the department offers. So it has a couple of components. It's primarily focused on supporting a network of 41 shelters on reserve across the country. As well, there's some programming dollars that communities are offered with respect to creating prevention programs around preventing family violence. So it's 2 components. It's supporting shelters and it's supporting some programming on a proposal-based basis.
Okay. When it comes to suicide prevention strategies that are delivered through the National Aboriginal Youth Suicide Prevention Strategy, do these suicide prevention programs include preventing child abuse? Like, I guess if it's driven by you're saying that these are programs that are driven by the communities that are applying for that family violence prevention program. Are there any suicide prevention parts that come into that the violence prevention program?
I'm just thinking, I would say typically they're not designed towards suicide, but I expect that the benefits of a number of those prevention programs might be ones that would also benefit prevention of a variety of types of violence or potential violence towards oneself, suicide prevention potentially.
Mr. Chair, I spent a little bit of time recently pulling together a bunch of stats. What was interesting was initially I thought, as my colleague across the way, Mr. McLeod, that it was generally typically economic reasons why there was such high rates of suicide. And just pulled a bunch of numbers, and it just going on like purely say the province or territory that they're on. The Nunavut has the highest rates of suicide. It also has the highest like weekly average income, which seemed counterintuitive to me. So if the weekly average income is really high, you would expect lower rates of suicide. It also has the most police officers. But it still continues to have the highest rate of suicide. And so it also has the highest rate of sexual violence. And so it was interesting to put those correlations together. Correlation never predicts causation. Is it because we have too many police officers that were causing suicide? Is it the sexual assault rate that's causing suicide? Or is it that these people are making more money that's causing suicide? It didn't seem to make any sense to me. But I was wondering if perhaps has those correlations been carried out at all? And this would be for Elaine there. Has those kind of correlations and perhaps some sort of causation on specifically probably income, sexual assault, and the suicide rate?
We have less than a minute, Dr. Baudin.
They're complex, but they all actually are part of the determinants of mental wellness.
There's some study that you could table that has those?
We could send you some articles, absolutely.
For sure, thank you.
Thanks. Next question is from Gary Anandasangri.
Thank you, Mr. Chair. I want to thank all of you for joining us today. I want to just distinguish between kind of short-term and a longer-term solution, and I want to kind of leave the longer-term out and just talk about the short-term, recognizing that a number of social determinants of health will have a significant impact on the longer-term, as well as the TRC and a lot of the things that Dr. Wong outlined. In terms of short-term, and let's say year, 2-year timeline, do we have a dashboard? Can we go through, is there somebody with a dashboard or a screen where we can say of the 600 communities that INAC serves, that say this 30 there's a high likelihood, or there's highly susceptible to suicide, or there's an increased risk in a certain period of time. The second group is a lower risk, and the third group has effectively no risk. Is there any metrics of that sort that's available that somebody's looking at continuously and deploying resources accordingly?
Yeah, we do. We do have a dashboard to actually precisely, look at that. And to us, that's really the equity issues, which is, you start with addressing the areas where there are lots of needs first, and then, with time, you start going into the second tier and the third tier. So that's, yes, short answers.
And with respect to that first tier, what kind of supports are being offered proactively, given the limitations that exist right now? What supports do you provide? How do you bring the provinces in? How do you bring the different agencies in to ensure that they're supported? Let's say the top 30 communities or the top tier communities are supported in that timeline that we're talking about.
Yeah, for those top tier high need communities, we are working with partners, with the communities, with First Nations communities, with Inuit communities, as well as with universities, with hospitals, with professionals, with professional groups, to actually try to actually see how we can actually find ways to expedite services, as well, to maximize the use of telemedicine in order to actually provide those mental health services. In addition, we also work with our partners, other government departments, as well as provinces and territories where appropriate, to actually find ways to actually address some of the other issues that beyond health. We want to actually bring in other partners, such as in looking at recreation. Looking at traditional activities, how to actually reinvigorate the language and culture, etc. So yes.
And is that top tier? Are those numbers static, or do they move around?
No, that unfortunately that top tier is not static. I mean, it's a dynamic, and it changes with time, and therefore our response, is also dynamic as well.
And what are your greatest challenges in reevaluating and fulfilling those needs as they arise?
Resources.
What kind of resources?
Both human resources at every single level, as well as financial resources.
And how do we start addressing the human resources? I know financial resources. There is a commitment right now from our government, 8.4 billion over the next 5 years. It'll go to some of these things, but really a lot of it is for infrastructure. But how do we address the resource deficit, which is, I guess I'm assuming it's professionals, it's doctors, psychiatrists, nurse practitioners, and so on. How do we address that in the short term? Are there locums? Are the medical associations involved? Are there nurse associations involved in supporting this right now?
Yeah, on the professional resources front, we are in discussion with medical schools, professional organizations, and nursing schools as well, in order to try to actually see whether there are ways that professionals can be mobilized to both offer services, whether it's regularly, or periodically, through a collaboration, together, with the communities. So, we are trying to facilitate, that from happening. Of course, working with provinces and territories. Already, we have a number of institutions being very interested, in actually trying to actually work in that capacity. As well, some of the medical schools and nursing schools, they have training programs as well. So we also facilitate, the encouragement of, training more trainees, both nurses and doctors, in order for them to actually eventually work in those remote and isolated areas on reserves. Yes.
Thank you, Dr. Wong. Next question is from David Yurdiga, please.
Well, thank you, Mr. Chair, and I'd like to thank the witnesses for being here today and presenting. Very informative. Some First Nation experience virtually no suicides in their communities, while others experience, 3, 4, 7 times the national average. What are the contributing factors that contribute to the higher suicide rates? Is there a magic thing when you compare communities to communities? And I open up the question to any of the witnesses.
If I understand your question, correctly, you're interested, in looking at what are the factors that determine, why a community, has a high risk for suicide and another a low risk for suicide. Is that?
That's correct. I mean,
yes.
You have two communities within proximity, and you have one that has a substantial lower suicide rate, and then you go 100 kilometers, and that other one has a high suicide rate. So geographically, they're in the same region, but the suicide rates are much different.
Yeah, Chandler and Lalonde have done remarkable study looking at that exact question. And to sum up, what they found was that there were a list of factors that are very important. But the very, very important factor is services and governance have to be determined and controlled by the community. So mental wellness services, other health services, education services, police services, et cetera, et cetera. What they found was that those are very, very important in order to actually reduce the rate of suicide, increase mental wellness, because it gives control, it gives the leadership to the community, for the community. Other people can actually assist, such as governments, but they are there to support. But the leadership and the control needs to be by the community and for the community. And this is in addition to all the social determinants of health that both Paul and myself have spoken about earlier, and of course the reconciliation part. Yes.
What I found in my riding is that one community is very active in other communities, whether it's sports, hockey. And it seems that the one that's very aggressive as far as being a participant with other communities, and they have a role model. The community rallies behind their teams. So have you found that in other regions?
Yes, indeed. Having recreational activities, sports activities, where there is a network to actually promote the youth from actually having a vision, a purpose in life. That's been found to be very helpful. How can you actually be living in a community where there's nothing to do? There's absolutely nothing to do. There's no sports. When you look to your left, look to your right. There's suicide of your friends, and there's no future. Whereas when there's a community, where a vibrant community, where the leadership of the community is very much controlling the education service, the recreational service, and the health services, it gives the young people a goal in life, and so that they participate in those activities, they excel in life, and they see role models that they can actually emulate, and those are some of the very, very key factors for successes in those communities.
Well, thank you. My next question, many Indigenous people in reserves find difficulty finding good jobs, long-term jobs. I mean, having a job for 1 month here and 2 months there is really not really a job. Has there been any studies done where employment and suicide is correlated? Is there any studies out there that say that yes, that's one of the contributing factors?
Yeah, there's a correlation between that. Yes.
Okay, thank you. Okay, what are some of the jurisdictional challenges that affect access to health services by First Nations and Inuit individuals?
Just about 30 seconds, I'm afraid.
Quickly, it's the isolation of the communities and for many of them, the lack of infrastructure, social infrastructure, as well as infrastructure, for accessing internet, for example. So all of those things are so important. Of course, we all know poverty and all the social determinants of health, the lack of recreation, the lack of linkages to the elders and their tradition. So, yes.
Well, thank you.
The last 5-minute question comes from Mike Bossier, please.
As the others have said, thank you very much for joining us here today in this very important subject. Many times it's been talked about strategy and framework and consultation. Is the consultation in establishing these strategies and frameworks around mental health and suicide and social determinants, is that just happening at the AFN level, or is that going right down to the reserve level?
Oh, much more than just the AFN level, and for Inuit it's more than just ITK, but with going down to the community level with different First Nations groups as well as Inuit groups when we talk about Inuit.
So do you know what % of different reserves you've actually consulted with, of the 634 reserves across country, territories?
I don't have that number off the top of my head, but a large percentage of that.
Okay.
Yes, over time, yes.
And CIHR, I know that you've been doing the same. You've been doing a lot of studies. I assume you're also going right down to the reserve level. It sounds like that's what.
Absolutely, we're working at community levels. For instance, the Access program, which is the major program on mental health in Indigenous population I talked about. I've been working on the grounds with the community Eskazoni First Nation, I mentioned it, the Sturgeon Lake First Nation, the Ilukatok Inunavut Southern region.
Okay, sorry.
So I could go on and on.
Yeah, exactly.
We are working with, we've also set up partners for engagement and knowledge exchange in the community to help us get the research evidence and the research results into the community, to work more closely with them and to learn how to actually work more closely with the community. And of course, to me, as I mentioned, a key element is to think of the future, is through education to support young Indigenous researchers. Their number is growing.
Well, actually, and that's where I'm going to get to. Is now you're working hand in glove, CIHR and Health Canada. You guys are working hand in glove together in these different communities, rolling out this research, identifying the hot spots, et cetera, et cetera.
we are working collaboratively not only with FINIB and Health Canada, but also with the Public Health Agency in Canada on these various issues. Absolutely, we're in the same portfolio.
What percentage of the people that are working in these specific areas with Indigenous peoples, how many of them are working for you are of Indigenous background?
Not enough.
What percent? If you had to throw a percent out there?
I don't have the numbers right now. What I can tell you, however, is the people working in the area of Aboriginal people's health, and I'm not talking only mental health now, but as you know, there's huge cross correlation between also other disorders and suicide. The number of people working, doing research on Indigenous people's health in 2000, when CIHR was created, were 37. The number of researchers working on Indigenous people's health issues right now is 1,174.
Okay, great.
Now, the number of Indigenous researchers has also increased, but not enough. And one of the problems that we're facing is, again, a problem of self-reliance, a problem of support, of mentoring, of maintaining the cultural identity and maintaining the contact with elders. So they're having in the research community role models, but they need to keep role models in their own community as well. So we've
okay. Sorry, I'm really running out of time here.
So we've developed a program to support that.
I guess that's where I'm going as well. Is how can we identify I know the challenges exist out there to trying to get more and more Indigenous people into these roles, but how long does it take to train somebody to be a mental health support individual within a community?
It's just you have to start education early on. You have to decrease the dropout rates in high school. You have to bring them to university, and once they're there, you have to build their self-reliance, their self-confidence.
Yeah, but I'm just looking at, once again, from a post-secondary standpoint. Is it a 4-year program? Is it 8 years? Is it?
But we're starting to get them in some projects while they're in the high school.
Okay, good. And that's what I guess I was going to. I'm out of time.
Sorry, Mr. Palacio.
So many questions.
We're moving to a 3-minute question now from Charlie Angus, please.
Thank you very much. Well, I was looking at the Pakanjikam coroner's recommendations from the horrific suicide crisis of 2006 to 2009. There were 100 recommendations. We will be having the Thunder Bay inquest recommendations. We've had the TRC recommendations. So, as ANDC, can they tell us in a case like that how many recommendations are followed up on?
So we're currently working right now to implement the calls to actions of the TRC. So that process has started.
But in the case of Pakanjikam?
I can't tell you off the top of my head, so I'd have to get back to you.
Because one of the key recommendations from Dr. Bert Lowers, who did the Pakanjikam report, and it strikes me as something to be learned in Attawapiskat, was one of the top recommendations was to establish a steering committee with health professionals, law enforcement, government in the community so that we could actually move forward. And that doesn't seem to have taken place. It seemed to have been a bit ad hoc, but that a coherent steering committee, and this is what we're hearing in Attawapiskat as well with the youth, of giving them something. But we see that there are partners stepping up. In Pakanjikam, Project Journey with the OPP is doing incredible work with young people. When Mr. Khan and I walked into Attawapiskat, we were met by the Canadian Rangers who are on the ground. So we have an enormous amount of goodwill. We have an enormous amount of expertise in providing services, but we need, in some of these communities, we need a framework. We need something, especially in troubled communities of crisis, the federal government or the provincial partner playing a role to support these efforts of organizations that want to help. So, Mr. Khan, I want to ask you, the clock's ticking on the EMAT team in Attawapiskat. People in our community have seen this movie before, that once all the attention's gone, one by one, so do all the workers, and we're back to square one. What's the post 30-day plan with EMAT and making sure that we can get the best out of all these organizations that want to help?
Thank you for the question. The EMAT team, and along with the federal resources, we have a senior executive from Health Canada as well as a representatives from the Northeast LIN, the Local Health Integration Network. They've been working with the community itself. The EMAT's been doing some knowledge transfer and training within the community, including the health director and other staff, to actually develop a transition plan as the EMAT sort of dissipates. There will be a plan in place in terms of medium-term supports, coordination. They've been doing some community mapping of all the agencies, the workers that are in place on a continual basis, but what is going to be augmented shortly between the collaboration and input of the Northeast LIN and the Waha Hospital. So those are being solidified. We're going to have some discussion, hopefully, with the chief on Thursday. So I think there's a reasonable plan. It's been a lot of hard work, but I think there's some light.
Applicable to other, I mean, it seems to me we're always reinventing the wheel in the middle of
I'm
a
afraid
crisis.
we're out of time, but your name's coming back up again.
Oh, 20 minutes?
Okay.
That's what it is.
Sorry about that.
We can talk.
Yeah.
So we're moving through the list. We're going to start again with 7-minute questions, and the first 7-minute question comes from Rémi Messet.
Merci, Monsieur le Président. Merci.
Thank you, Chair, for participating in this crucial initiative to cast light on the causes and possible solutions to lower the high suicide rate. My first question is for Dr. Baudet. Our colleague Cathy McLeod alluded to this earlier, but unfortunately there wasn't enough time. Could you tell us more about potential solutions that have been implemented, successful solutions used in Quebec that led to a decrease of 50% in the suicide rate among youth? Could you tell us more about those solutions? I could send you details. It's a government program with prevention policies that are very structured. As your colleague was saying earlier, we're faced with a common dilemma in research. There is a correlation here, a decrease in suicide rates in Quebec currently, and that's a stable decrease year after year. The suicide rate is decreasing, and that's absolutely remarkable. But what we don't know is which elements of the preventive programming have had this effect. Establishing a causal link is difficult. I would be happy to send you more documentation about that. However, what is entirely clear, and we've seen this by studying what's been done in Greenland, in the United States, in Australia, and in Canada to prevent suicide, what's entirely clear is that these interventions need to be linked to local communities and social cultural patterns, to community engagement, as my colleague said, and to the existence of role models for youth. And that varies widely from one community to the next. And the more remote the communities, the more different they each are from each other. So we cannot adopt Quebec's prevention strategies lock, stock, and barrel and apply them all over the country. That's crucial to remember, but we should also try to distinguish which elements can be adopted and adapted for different communities. A researcher in Quebec has found a way to isolate elements that can be applied elsewhere, and she met with success, so that is a possible solution, and it's something that should be examined closely. Well, thank you, and even if the suicide rate has swan dived, according to these statistics, it's 753 for men and 219 for women in Quebec. So there's still a lot to be done. It was alarming. Not long ago, it was one of the worst situations in the world. And now there's still a serious situation among young Inuit men, where we hold the tragic record of the highest level of suicide in the world. I have another question for the representatives of Health Canada, who've implemented the Aboriginal Health Initiative. In July 2015, the government announced a continuous funding system of $13.5 million per year to the National Youth Suicide Prevention Strategy. How many of these suicide prevention programs have been funded under this national strategy? And what have the concrete results of those programs been?
Yes, thank you very much for your question. Indeed, the strategy has funded more than 130 projects. For me, that's just a start, because many, many more projects could be funded with additional resources in the future. But some of the outcomes we're already seeing in some of the projects, some of the participants are reporting that they are seeing more hope. They are seeing a future for them, and they are starting to actually attend school more. And those are all elements to actually predict a better future, and therefore a less propensity for mental diseases and suicide as well. So.
Merci. Est-ce que vous pouvez décrire, par exemple,
Can you describe, for example, some examples of projects that were implemented among the 130 programs you mentioned, to give us an idea of what's been done? To help answer my colleague Michael McLeod's question, to get an idea of what concrete solutions have been implemented.
Yes, very much so. For example, I was talking about earlier. There's a project in Northwest Territories, where there was a camp, for young adolescent girls and teens. And through the camp activities, that they've learned to actually have self-confidence, and they actually learn about the linkage to culture, and as a result of that, they are actually reporting all of those factors that I talked about. The feeling of hope, the feeling of a future, and as a result of that, their connection to schools, et cetera, all of those things have increased. Also, another project was through the development of community working together with the local police to actually try to actually help the young people to understand their strengths, and help them to do physical activities, and as a result of that, they are finding that they find that they will no longer be actually complaining that there's nothing to do in life. They actually now seeing that, look, there is a place for me in the future. So thank you.
Thank you very much for that. The next question is Kathy McLeod, please.
Thank you, Chair. And, I do want to pick up on my namesake over there in terms of the fact that it doesn't appear to be one sort of lead in this. And so I think it seems that, like, the sense I'm getting is sort of a scattering of services and programs across a whole host of departments. Some have been evaluated, some haven't, and so I guess, there's certainly, I think, ways that it can be brought together in a little, with a little bit more clarity, but you've been embedded in the system and perhaps you see it more clearly than I do. I do want to also pick up, I think if you had the money tomorrow, you would never be able to fill 70 teams of mental health workers. I mean, I've delivered health care, been responsible for getting services in rural and remote communities, and I think it is really tough in terms of HR manpower and getting people with the right skills. So I always sort of believe that to some degree the money is better spent in terms of recreation and capacity building. And so to that end, first of all, I want to find out, I know that Dr. Baudet again talked about the mental health first aid program being adapted to First Nations communities, being rolled out. Number one, is it being rolled out in 600 communities across the country or 20 communities? To what degree has it been evaluated, and to what degree is it showing any kind of results?
So the answer is no, not to the 600 communities. I'm sorry. Well, as we're funding research, right? So our role is to demonstrate that an intervention is effective. And then our role is to work with our colleagues to ensure that the effective interventions are scaled up in a way that is appropriate for the various communities where they're being scaled up.
So how many communities are you researching? So the program was adapted?
It depends on the programs, but
This is the mental health
where
first
there
aid
where there are 12 communities in one program, same number. They're relatively small numbers of communities where the research is carried out. Don't forget that again, we support the research, so we cannot support care, which often goes with implementation science, to a very large scale.
Okay, so my next question I will go to Health Canada. I've seen demonstration project after research project after primary healthcare project that is shown to be effective. Do you have a system whereby you can reallocate resources from things that aren't effective to, so let's say this, for example, this mental health, the first aid kit was showing amazing results. What kind of nimbleness and flexibility have you got to scale that kind of thing up?
It's for me?
No, it's for Health Canada.
Yeah.
So the results come in from CIHR. The mental health toolkit is amazing. How are you going to scale that up?
One of the ways we actually do it, working together with CIHR, Health Canada, First Nation Inuit Health Branch, actually, collaborate with CIHR on the Aboriginal Pathway initiatives. And that's an initiative that includes, among others, one of the component is actually, mental health and suicide. And so because, we actually collaborate, with CIHR, out of those, projects, when, there's demonstration projects showing that, there's promising practices, we actually, through our networks, facilitate the sharing of, those best practices and promising practices. In addition, we internally reallocate funding working together with communities in order to try to actually scale up, those promising practices. As part of a CIHR, perhaps Dr. Baudet can actually mention as well, there's a small scale-up component, to the Pathway project as well.
There is, absolutely.
Sorry, I was, and I think we'll probably have to take this offline, because how many of the communities, the 600 and some, have reasonable broadband access? Available, to what degree is telemedicine, and also things like I think there's some very good preventative kind of mental health programs that are quite catchy for young adults in terms of these online supports, like Walk Along. So are we scaled up across the country for broadband? Are we scaled up across the country in terms of the ability in the majority of the communities, 50% of the communities, to deliver both telemedicine and to have capacity to administer some programs that are perhaps effective?
Short answer is not enough. We really, would like in the future to have enough bandwidth and broadband so that those services can be actually brought to the remotest fly-in communities. But at the moment, unfortunately,
50%?
Less than that, yes. And many of the communities, remember that it's a dial-up. So dial-up, for actually doing any kind of download is extremely slow. So.
And just if I may add, scaling up is not easy. And we're realizing that it's a problem that we're facing worldwide. I mean, the World Bank is coming to us to ask, okay, how do you scale up projects in Western Africa? How do you deal with the different cultural background and scale up a project? We're dealing with a science which is a new science, the science of scaling up. What does it work? How do you do it? How do you do it efficiently? And I think we're just seeing the beginning of that, and we'll be way more effective in scaling up in the near future.
You're at 6:35.
Thank you.
Okay, thank you. The next, and I believe it will be the final question, will go to Charlie Angus, and I think the bells might start to ring, or the lights will blink while we're in this question. It's a 30-minute bell, I understand, for a 6:45 vote, so we should be fine to get through it.
Mr. Chair. Thank you for this. It's been a very interesting afternoon. I want to go back to the issue of child welfare, because it appears in the case of this young person that was lost in Lake of the Woods. It's been raised again and again as one of the key drivers in terms of the lack of opportunities for Indigenous children. So your government has placed $71 million for immediate relief, I understand, for responding to the child welfare gap. But I'm looking at your own submission to the Human Rights Tribunal, which was tab 248, that says at the time that it was submitted that the gap was $108 million, which now with inflation would be about $121, $122 million. So your own internal document said that the gap was much larger than what's been provided. So how can you be in compliance with the Human Rights Tribunal ruling, which has ordered you to immediately end the underfunding?
So when we had, sorry.
Isaac, if I could just, our procedure requires me to ask for unanimous consent for the committee to carry on when the bells are ringing. And like I said, it's a 6:45 vote. Do we have a unanimous consent to carry on to the end of this 7-minute question? Okay, it looks like we have it. Sorry for the interruption. Please proceed.
No. Thank you, Mr. Chair. So when we had undertaken that work in 2012, we had also looked at scaling up the funding, and so that's what the current budget investments do. So they start at 71 million and scale up all the way to 176 million over the 5 years and then ongoing. And that is the same philosophy that we had looked at when we had done that previous work, is that agencies needed to ensure that they could hire and get the appropriate social workers and the appropriate programs in place in order to expend the dollars over time. So that was the thinking behind the scaling up of the money over the number of years, and that was the same thinking that existed when we had done the previous thinking.
Okay, so I mean, I guess the question though, in terms of being in immediate compliance, because we're talking about children who are falling through the cracks nightly and daily, that in 2012 you'd identified a gap that is much larger than now. So the scaling up is going to take 5 years, but at the end of that 5 years, you still will not be at the $200 million, which is what the litigants against the government are saying is the shortfall. So if the Human Rights Tribunal has ruled in favor of Cindy Blackstock, and she says it's $200 million, and in 5 years you're still not going to be there, then how can you be in compliance with the ruling?
So the tribunal, as of to date, hasn't indicated that 200 million is the number for compliance. They have asked for the information which we've just recently provided the detailed breakdown, and we expect will get back to us if they have further questions or further order. So as I said, we've updated the numbers that we had used in 2012, which showed ultimately a $108 million gap, to now we see about a $175 million gap in ramping up. So it remains to be seen if the tribunal has more information for us.
So what happens if the tribunal says it doesn't cut it? Then you're, I mean, this has been a 12-year process. They've been telling you, or you've been aware of this, your own documents show that that the numbers are serious. How do you become in compliance if your plan is over 5 years to not even meet the target? Do you have a contingency plan then at that point?
We will address what the tribunal orders us. We will look at the order at the time and address it at the time.
So would that money come out of other program dollars then? Like, because that's what's happened in the past, right? Money's coming out of infrastructure to deal with shortfalls in child welfare. every year?
In the past, we had reallocated money, that's right.
Right.
So now the hope is that we will not have to reallocate money from other programs.
Right.
So we will deal with the tribunal order in the future should they order something different.
So 71 million is what's going out, what's been allocated. Do you know how much money is expected to actually go out to service children?
So I don't have the detailed breakdown right in front of me, but we've provided that breakdown and we can do so to the committee.
Okay, that'd be good because, if it's only 50 million and the rest is being held back for whatever other administrative issues, then we're still not being compliant. So that would be helpful.
We'll provide
to
the
us.
breakdown.
Thank you very much. Dr. Wong, I wanted to return to you on terms of staffing up to wherever we're going to go with the mental wellness teams. If we have 10 mental wellness teams, I don't know, servicing 5, 10, 20% maximum, and we need to get to 80. Do you have, are there targeted plans in terms of how we get there? I mean, are we just hoping or?
No. We actually, right now, seeking, sources of, resources and sources of funding. As I said, before, 10 teams is not sufficient,
Yeah.
and so we'd like to actually, increase it. If we actually look at, 80 teams, we'd be looking at, $40 to $50 million.
Okay, so but you'd need to find that, so that would have to come from Treasury Board. So that's roughly the area of what you need to meet that shortfall?
Approximately, yes.
Okay, thank you. I guess my other question is Doctor, je voudrais suivre une question de ma collègue de Monsieur Massé.
Following up on my colleague, Mr. Massé's question, the lowering in the rate of suicide in Quebec is remarkable. The difference between the Cree of Quebec and Ontario and the Ontario Cree is a night and day. My question is, in Quebec, there was an agreement between the Cree and the government of Quebec establishing a process of commitment for developing resources, developing the economy, and protecting the territory. And that's a completely different situation than the situation for the Cree of James Bay in Ontario. Do you believe there's any kind of a link between the improvement of the economic conditions for the Quebec Cree and the decrease in suicide rates in Quebec? I don't have an exact answer to that question, and as I said earlier, there was a series of preventive measures taken by the government, an increase in access to mental health care, an increased access to suicide prevention services, including even physical barriers along a rail, on long railways to prevent people from throwing themselves under the train. So it's hard to make a specific causal link here, so I can't give you an exact answer.
I wish to thank all of the witnesses today for your time and your very thoughtful presentations. Your contribution will make a tremendous impact on our study. Thank you very much. May I have a motion to adjourn, please? We're adjourned. Thank you.